Yep, good.
All right.
Okay, let's start again. Hi everyone, I'm Chrissy Kelly of AbScent.
I'm Simon Gain of the Royal National Throat, Nose and Ear Hospital and the London Nose and Sinus Clinic and AbScent.
So we are here for our third Facebook Live event, so thank you for joining us. I see we've got a couple of people watching now, so that's great news. We have our nose model here handy, just in case anybody has any questions. So Simon will model that a little bit later on. So thank you for posting your questions so far this week. Let's get right down to it. The first question that we had is about stem cell therapy. So Simon, what can you tell us about stem cell therapy?
Where to begin? So maybe the best place to start before we go on to stem cell therapy and olfaction is what are stem cells? And stem cells are very sexy technology because almost everything in the body is made of cells, and those cells have specific roles. And the way that they differentiate from the sort of the basic what's called a multipotent stem cell is that through their maturation they become not just a basic cell, but they become a bone cell, for instance, or a skin cell or something like that. And that's a process called differentiation. And the whole idea behind stem cells is that if you can put the basic building blocks, these pluripotent or multipotent cells that can become anything that they want, maybe you can regenerate a whole tissue. Maybe you can regenerate the bone or the skin that you've lost in some way.
Right.
And maybe, so in terms of smell, maybe you can regenerate the olfactory sensory neurons, the nerve cells that do the smelling in the nose, and grow them back so that you can regrow the sense of smell.
So what's the likelihood that that would happen? I mean, how far has the research come so far?
Well, so the good news is that the sense of smell is actually the olfactory epithelium, the lining of the nose that does the smelling, has these nerve cells in it that do the smelling. That's happening all the time. We have stem cells in our nose called the basal cells that are regenerating all the time. It's one of the only places in the central nervous system where this happens.
And can I just ask a question? Am I right in thinking that they have used these basal cells in other kinds of research to regenerate? Is that, were they not using that?
No, that was in olfactory and sheathing glia.
Oh, okay,
So,
sorry.
yeah, we can talk about that as well. But
Okay.
so if you take the olfactory lining of the nose and you look at it under the microscope, you can see the nerve cells being regenerated all the time, coming from these basal cells all the time. So in theory, we should be able to, if we can just find the molecular switch, hopefully turn this on. And part of the trick where this is happening is to do with those olfactory and sheathing glial cells. So when you have a nerve, you can think of it like an electric wire, and it works much better if you have insulation wrapping around it. And the insulation are these olfactory and sheathing glial cells. They're the plastic around your electrical cable.
Right.
And they, in some way, and that's why they were used in these spinal cell regeneration experiments, in some way allow regeneration, allow this cell to grow to the right place in the brain, in the olfactory bulb, to rewire that sense of smell. And it's happening all the time. So we're, as people who are interested in smell and smell problems, we're actually potentially in a very good position to use stem cell therapy. But injecting stem cells or anything else is probably not the way that's going to go. Those stem cells are already there in most people. We need to find a way of switching them.
Right. There was that study that came out of Hungary that was just a small number of patients.
The plasma.
That created such interest, a lot of headlines, things like that. A lot of questions about that in the various Facebook groups. But at the moment, that's not looking like a very well-run study, and that it hasn't been reproduced. Is that?
No,
or is it
and I'm not sure anybody has looked at. I mean, yeah, the central problem is it doesn't look like a study that was run at all. It was a collection of random people who they tried this with, without any proper control on even whether or not they had smell loss in the first place.
Right. Okay, thank you, Simon. So let's go on to the next question. And this one is about eustachian tube inflammation with sinus infections. I know this was a question put forward by one of the people that commented on the announcement about this Facebook Live. So, is that a common thing, eustachian tube inflammation? And do you have any comments on that, in particular on itchy ears?
Okay, so yes, eustachian. So what I think we should do is distinguish between eustachian tube inflammation and eustachian tube problems.
Let's start by saying,
get the ear.
Let's get the ear out.
And itchy ears. So, but we're going to just start with a little bit of anatomy. So this is our ear model. And this is a slice through the ears. If you can imagine chopping my head in half this way, swinging my face off,
no, Simon.
and then looking at this chop through. So there's the end on ear, and now we're looking down. This is the ear canal. This is the eardrum. This is the middle ear, and this down here is the eustachian tube.
And important because it also it feeds from the sinuses.
Well, it's right at the back of the nose, so not the sinuses, but the back of the nose in what's called the postnasal space.
Right.
It ends in a little sort of cushion here, and that's just behind the back of the nose as it joins the tube that goes down behind your mouth into the gullet and airway.
Right.
And that's the eustachian tube. So the important thing about that is that it is lined, you can see there, by that pink lining there, and that's very important because that's respiratory epithelium. In the same way as your nose is lined by respiratory epithelium, which is the thin lining of the whole of the nose, the back of the mouth, down into the trachea. All of it is lined by this very thin, very fine mucus-making lining. That is also lined by the same thing. So anything that affects the respiratory lining, the respiratory epithelium or respiratory mucosa as it's called, can affect the eustachian tube. So allergies are expressed in the nose, they can be expressed in the eustachian tube. Chronic rhinosinusitis with or without nasal polyps expressed in the nose, they can affect the eustachian tube. Diseases like vasculitis, Scherg-Strauss or Wegener's, they can affect the ear as well. So all of those things can affect the ear and the eustachian tube proper. And that for me is always a red flag. If I see somebody with proper eustachian tube involvement, I'm always looking, is this something more than just an eosinophilic chronic rhinosinusitis? Is it a vasculitis? This is obviously very severe. It would make me more aggressive in my management with medical therapy, with steroids and things like that. So it definitely happens, and it's very important to be picked up and to guide therapy and further investigations. Itchy ears are a whole quagmire of a different subject. So itchy ears are very complex because when you're talking about the ear, you're talking about all of that. The pinna, the ear as we normally think about it, the canal, the drum, the middle ear, the eustachian tube, and there are a fair number of nerves that supply different parts of all of that. All of those nerves go to different places and supply other places within the head and neck.
Yeah,
so for instance,
and can I just stop you right there, because we were talking before we went on air, we were talking about how you might feel an itch in the ear, but it might be having its origin elsewhere.
Exactly, in the voice box, for instance. And so that to ENT surgeons is always concerning, because a small number of people with laryngeal cancer, for instance, will present with ear pain, severe ear pain, and you always have to look at the voice box before, as well as looking at the ear. So itching and irritation anywhere in the aerodigestive tract can give you itchy ears. So it's not just eustachian tube dysfunction. You have to look at it.
What about the relationship between eustachian tube inflammation and sort of sinus issues? Is that so? They are connected.
Yeah. So sometimes, I mean, eustachian tube function is again not very well understood at the moment. So the tube itself is cartilage and lining with the respiratory epithelium and muscle. So all of these things can be involved, and those little cushions that I was talking about, where they enter the postnasal space, can be thinned and give problems. So it's quite complex. It's not just the lining. But because if the lining can be involved with rhinitis, with inflammation in the nose, sinusitis, inflammation in the sinusitis, and it can in the sinuses, then it can be involved in inflammation in the ear and middle ear and Eustachian tube.
Okay, great, thank you. So we're going to move right along because I know we've got lots of questions here, and I see that Karen has just posted another one, so we'll try and get to all of them. The next question is about probiotic powders for the sinuses. So that sounds like something that would make me sneeze. What do you think about that?
I think in every single Facebook Live that we've done this far, we get to this point where we're at the edge of what we know about the nose, and also how do we know what we know? So how do we know whether probiotic powders are going to be useful? Well, that's where the science comes in. But what you need to do is to take two groups of people, give with the same symptoms and presumably the same disease, give half of them the probiotic powder and half of them not, and see what happens to them.
Right.
Now, this is even more complex than that, because we're now beginning to understand, I think as we said the last time, that these diseases are not one disease. Even people who have polyps may have different diseases that just look the same when you look in the nose. They both have polyps, but actually when you start looking at the way their immune system functions, it's different. You see whether there's inflammation around the blood vessels, like a vasculitis or not. All of these things lead us in to make different disease diagnoses. So what works for one might not work for another, and vice versa. So it's very, very messy at the moment.
Right.
And so when we get to we've looked at the evidence for probiotic powders in sinuses, and really there isn't that much. There's something that indicates it might be helpful. Another paper that says that it doesn't really seem to be helpful. And again, we're dealing with the same thing. We don't actually even understand what the normal microbiome is like in the nose.
Yeah, and of course everyone will have a different microbiome.
Yep.
It's a bit like the gut microbiome. If you live in one country, you might have a different one than if you live or maybe if you live in a humid environment, it will be different from someone that lives in a dry environment. So
and teasing, because it's so complex, it's not just going to be one bug. It might be an interaction between three species of bugs. We just don't know. It's very, very complex. So when Chrissy first mentioned it to me, I said, well, it's probably not going to do any harm. And I still think that's probably true. I mean, we're all inhaling bugs all the time. Inhaling more of one bug probably doesn't make much of a difference, but we just don't know. And this is a very complex subject. And don't forget that most sinus disease, even if it feels like recurrent sinus infection, that may well not be the infection that's causing the problem. Maybe an immune deficiency, maybe something else going on, inflammation in the body that looks like an infection because that's how the body fights infection, but there is no infection happening. It's just the body starting that fight on its own.
Right.
So it's just very messy at the moment. So
now I'm going to interrupt you because we spoke before we went live, and I asked Simon, just because this has just come up, what's the likelihood that any ENT that you go to would know enough about all the complexities that are involved in sinus disease, in CRS with and without polyps, with all the kinds of things that can go wrong. And it can be so frustrating for a patient to go to doctor after doctor who doesn't have the background knowledge. So what would be your recommendation for someone who really feels that they have not so far spoken to anyone who really understands what might be going on?
It is very difficult. I mean, finding an expert in a very small field.
And that's what this
difficult.
is, a very small field.
It is. And this is where you come in, Chrissy. It's fine, and I think this is the power of patient information groups and organisation outside of the traditional medical hierarchy. This is where you can actually ask people and say, do you feel that this is right? And I would always say, if you feel that you haven't got the right answer or haven't even been taken seriously, then get a second opinion or a third opinion or a fourth opinion. It may take some time, and put the word out amongst people who who may have been through the same thing, they'll be able to give you, guidance on that.
Yep.
But
and that might also be a good thing to put out to you who are watching this. If you've had good care,
Yes.
if you've had a sympathetic doctor who's treated you, or who you feel has done all the necessaries and done it in a way that's made you feel better, because really what we want is for people to feel better in all ways, then do please post. We've had a couple of posts like that, and I think that's an important thing to do, is that
Absolutely.
people recognize, so that we know who the good doctors
and the professionals need to be pointed out, and if they've helped you, then they're likely to help other people. It's not just a matter of knowledge and of skill, but also of temperament. Some people just get on with they find the doctor's approach to be what they want, and there's no. I mean, I firmly believe that every doctor should be, and most of them are happy to have a patient seek a second opinion.
Right.
Because you don't always get it right.
Yeah.
We should have the humility to accept that.
Okay, the next question comes from Steve, and this is about stuffiness and parosmia. And the question arises, why is it that the parosmia will appear on one side and people will feel, and very often what they say is, that it is, the parosmia is always on one side. So can you tell us a little bit more about that? Because this is something that people have said to me before. For me, my parosmia was on both sides, but let's hear a little bit more about how that might happen.
Yeah, I'm still not, well, if we knew what caused parosmia, we might have a better understanding, and we're getting close to that. I mean, it's obviously a disturbance in the way that the olfactants are processed within the brain,
right?
And it could be the signals from one side do go mostly to that part of the bulb on the same side, but there's quite a lot of crossover to the olfactory bulb, the part of the brain that's sitting above the nose that does the first stage processing of this thing. There's a lot of cross-link between the two, so it's difficult for me to really say, it's going to be on one side or the other. But you can imagine a lesion, something going wrong in somewhere on one side that's perceived as being on that side. But the link between that and the stuffiness is difficult to explain. So stuffiness is the feeling of obstruction within the nose, and there are two parts to that. The first is there really an obstruction? Is there something blocking it, or is it an alteration in the airflow that is causing an objective change in the flow of the air through the nose? And that's one thing. The second is the sensation of obstruction. So we sense how open our noses are, but through a nerve called the trigeminal nerve, which is the other major sensory nerve in the nose. So when we're smelling something, we're not only getting stimulation of the first nerve, the olfactory nerve, you're also getting some trigeminal nerve. And this is really important for those of you who have smell loss, that it's still a way of getting some sensation from food and from the environment in a way where if you lose the first nerve, the trigeminal, the fifth nerve, can still provide some input. So those are things like eucalyptus or
spice, chili, ginger, menthol.
All of those, direct stimulation of the touch sense in the nose. And openness in the nose is sensed actually via the cold receptors in the nose. So whether there's...
so wait, so what you're saying is that it's the trigeminal nerve that tells you that air is whooshing into your nose.
No, the cold receptors on the trigeminal nose that tell.
Right.
So it's actually evaporation of the air, of fluid, causing cooling as the air flows through the nose.
Okay, so that's those little Vicks inhaler things.
That's how they work.
That's a bit of a, that's tricking you into thinking that you've got more open nasal passageways.
And people have looked at this. It doesn't open your nasal passages at all.
Yeah, interesting.
But it makes it feel like it does.
Yeah.
Because you're getting direct stimulation of those receptors. And so what's therefore the challenge is to say, well, we're seeing a disturbance in the first nerve and potentially a disturbance in the fifth nerve. They go via completely different routes in the, one goes to the brainstem, the other goes straight into the brain. They don't share pathways at all. How can you say that there's an interaction between the two? And this is where we come on to a very interesting part of sensory science, which is cross-modal interaction. So this. And
what does that mean, cross-modal?
So when we talk about a sensory modality, we're talking about vision and hearing, or smell, vision, hearing, touch.
Right.
So it's just a way of saying interaction between the senses. But there's a lot of processing the brain does to put senses together to make sense of the world. So I think one of the classic examples, and there's quite a famous psychologist in Oxford called Charles Spence, who has the cross-modal lab there looking at these interactions. And one of his famous experiments was looking at potato chips or crisps, and basically giving people noise-cancelling headphones, and then playing the sound of a very crisp, fresh crisp or a stale crisp when they bit into a crisp. So they would get the crunch of a fresh crisp, or a sort of that slightly more muted stale crisp sound, and they could not tell the difference between fresh and stale crisps
in their mouths, except by the sound. Interesting.
Very interesting.
So in other words, they were fooled into thinking they were eating a fresh crisp
when it was stale.
Even if it was stale, if you used the sound of fresh crisps.
Sound.
Very interesting. Yeah. So that's multimodal for you.
Yeah. And so maybe, I mean, this without seeing the person and seeing whether they had an objective blockage, that may be one thing. So we're looking at a cross-modal effect. You're feeling a change in the sensation on one side, and that's interpreted not only as smell but also as trigeminal.
It's interesting the way, because I heard somebody else talk about this, the way you read the signals that you think you're getting from a stuffy nose. I actually had to have Novocaine. I had some dental work done, and this numbed the kind of lower part of my nose, and that's a very strange sensation, because you feel like you're not breathing through your nose, and you have to keep sort of checking. So the brain plays tricks on what we perceive from our noses. I think that's probably a good message.
Yeah, I mean, so one of these questions was about waking up first thing in the morning. So again, the nose is not just a hole in your head that you breathe through. It's under direct neural control as well. So the nerves control, and actually there's a reflex from the armpit to the nose on that side.
Really?
Yes. So when you lie down on that side, the body knows and closes off the downward nostril.
Oh, I've learned something today.
Wow. There's an old yoga practice about using a crutch in the armpit to block off the nose on that side. So it's a reflex.
Interesting. Okay.
So that's the other thing I can think of. Maybe you're just lying on that side and waking up, and that's why it's...
Right. Okay. Another thing that Steve asked was whether or not all inflammation shows up on a scan. So when you go back to the ENT and the ENT says, oh no, everything looks fine, there's no inflammation, but yet you feel that there's inflammation. What do you think's going on there?
So again, I'd distinguish between stuffiness, blockage, obstruction, and the feeling of all those things, and inflammation. Inflammation is just one cause of those things. Yes, generally anything other than the very mildest of colds will show up on a scan, because you'll see thickening of the soft tissue. But there are plenty of other reasons that you can have a blocked nose and not have any changes of inflammation. And some of those obstructions don't show up on a scan either.
Right. Okay.
Just because of the way it
Okay.
works.
Thank you. And now a more general question about why the sense of smell gets so little attention, both from healthcare providers, but also kind of in a larger sense, in society. We don't really talk about the sense of smell. Smell is invisible. We all depend upon it without knowing it. Do you have anything to offer that? I mean, it's an age-old question. So what do you say?
Well, there are a couple of points. The first is that smell is a very, very old sense. It's probably, if you think about it as chemodetection or chemoreception, it's the oldest sense that there is. You know, little amoebae, before they were multicellular organisms, had to still sense the environment, and the environment they sensed was chemical.
Right.
So they're doing this all the time.
Just explain to people the link between, I mean, why is olfaction called a chemical sense? Where are the chemicals in there?
The olfaction, the olfaction is the direct appreciation of chemicals within the environment.
Right.
That's what smells. That's
volatile molecules.
Pulling them out of the air
Yep.
and detecting them and telling what they are.
Okay.
And by telling what they are, you can tell where they come from and so on.
Okay.
So, so that smell and taste together, the oldest sense, and because and there are a couple of reasons why this has become less important for humans. It's the oldest sense, and it's probably the most poorly integrated into our sensorium as a whole, or to our conscious mind rather. So if you look at the rhinencephalon, the bit of the brain that does understanding of smell, that's 4-layer rather than 6-layer as it is everywhere else in the brain.
Right.
So it's more primitive, if you want.
Right.
It's hooked into the more primitive areas, like those to do with emotion and instinct and memory, not with the higher frontal processes to do with what we call higher functions. And therefore probably even though it might be important, it is less salient in our minds.
Right.
So that's one reason, because it's just that's the way it is. But then you have to go a little bit further and say, well, why is it that way? Why have we not bothered to integrate that into sort of ongoing conscious perception in the same way we have with vision and smell? And that may be due to evolutionary factors. There was an interesting paper a while ago looking at the rise of trichromatic vision, so 3-color vision,
Right.
and the relative increase in the amount of mistakes in the genome, in the genes for smell.
Mm-hmm.
That has been retracted, that paper, but it's an interesting point that if your other senses are better for what you need to do as an evolutionary niche or evolutionary role, then you're going to be spending more resources on keeping them up to date.
Mm-hmm.
You know, you can afford some mistakes in your genes for smell if it's not as important for your survival as vision or hearing.
Because we have a huge number of genes that are devoted to the olfactory system. Is that right?
Mm-hmm.
Yeah. Many more than you would think would be necessary.
But many more of those have mistakes. So we have about 300, depending on the person, 350 to 400 different types of active olfactory receptors. But we have many more that are inactive,
Right.
that have been broken by mutation and just because they didn't make a difference or a significant difference, we just accept them as being broken.
Right.
Whereas, you know, a rat or a mouse who relies on their smell all the time, they've got 1,000.
Oh, right. Okay.
Over 1,000.
Okay.
So it's there are other factors as well, because of this lack of salience, because it's not part of the way we evolve to hunt and to be successful, and because it's not part of the way we think, then people think that it's not important because
Right.
it's not an experienced part of their lives. But actually, as everybody who's lost their sense of smell knows, once you lose your sense of smell, for a lot of people, they realize how very, very important it was.
Oh, yes, absolutely.
I'm preaching to the choir.
Yeah, right. I mean, also culturally, I think with the Victorians came this notion that the human body was sort of unclean and needed lots and lots of washing and to sort of remove anything that might have any kind of an odor. So, you know, culturally we are, even if you use the word smell in public, everyone kind of flinches because it has a negative connotation. So I think we're always.
Yeah, I blame Hollywood.
Do you? Why?
Why? Because what we have entertainment that is visually entertaining, auditorily entertaining, but the rest of the senses are unstimulated by it.
Right.
And so we have these idols, whatever, the screen idols who This is an idol theory, by the way. But the screen idols that you look up to, the beautiful, who are in their essence have no smell. They have no physical reality. And so the first thing that you learn to be attracted to is something that doesn't have a sense of smell, or doesn't have an physical
doesn't
presence.
have a perceived odor.
Yeah.
Well, there we go. So the next, coming soon,
that's my theory.
Olfactory entertainment. Right. So the next question that we had was about Cold-Stop, which is, for those of you who have been following what's going on in the Facebook page, Cold-Stop is a German over-the-counter remedy. There's a base oil, and in it they put vitamin A, and there's been some research on this. So Simon, maybe you'll tell us a little bit about that.
Only preliminary at the moment, but if I lost my sense of smell, I think I would get hold of some and to start with the regeneration process. We are lacking a really clear mechanism, and we are lacking a really clear, as we're going back to the same thing, clear placebo-controlled randomized trial of the use of Cold-Stop. But there is anecdotal evidence and some non-anecdotal evidence that actually it does help in the recovery, especially post-viral.
Right, okay.
So I again, it's one of those things where I don't think it's going to make things worse. It's available over the counter in some countries.
It was, I know that for a long time it was not available in other countries, but there have been a couple of posts here in this group about people who have managed to mail order it to the United States. So it might be worth checking again if you live in the US or the UK and you tried unsuccessfully in the past to mail order Cold-Stop. I would definitely try again. Right, okay, the next question is, what percentage of people who have parosmia actually go back to an undistorted sense of smell?
I don't have a number for that, for percentage. It's good, I know that much, but I wouldn't ever put on a percentage chance for anybody who's in that position. It does get better, and I mean, you're more of an expert than I am.
Right. I mean, for me, so my smell loss happened 7 years ago. I had a virus. It was total loss to start with. Then, like many of you, I started having kind of vague smell experiences that I wouldn't really describe as a smell. Then it went into full-blown parosmia, really awful, difficult to eat, difficult to feed the family, you know, all the associated problems that you're all well aware of. What I do find is that I still have some distortion, but I really seem to, my brain is kind of filled in the blanks, and now it doesn't bother me. And I said to actually a doctor that I was speaking to about this, for me, it's a bit like moving to the new world. You know, you've moved to a new continent, and it's not the same. The weather's not the same. The food's not the same. But you've moved to a new place, and you have the views there are also beautiful, and the food there is also good. And I just seem to have come to terms with it, and I feel happy. And I think it's a really important distinction here. So many people come into the group and they want to know, am I ever going to get better? And I think we have to define better. I don't think there is a cure for smell loss as we experience it. I think that you have to talk about levels of healing, and most importantly, a return to quality of life. In the same way that you could never recover from a really bad car accident and look exactly the same, you would have limbs that had, you know, healed, and, you know, broken bones, and you might have had terrible lacerations, so that you will have scars, but one day you'll feel good enough to go out and face the world again. And I think that's really where we need to go. It's quality of life issue. So that's just my take on it.
Would you say nobody gets better? I think there are some people who get.
I think
maybe diminished, but they get.
I think there are people who seem to experience no more distortions.
Oh,
I've met plenty of people like that. There are people who remain experiencing the world in a distorted way that still makes them miserable years later. So I think there's a whole spectrum out there.
Yeah. And there are some medical treatments for when it's with parosmia does get quite bad. But I think coming to terms with it, I do think smell training helps. It does help. We know it helps. And I think learning to appreciate what you have is, yeah.
And I think also it's a good time to say that one of the things that smell training does is it makes you more aware. And the more awareness you have, the more you can kind of look inside every smell experience and see different components. You know, you can kind of pull apart a smell, and you can experience the things that are good in that smell, as well as recognize the things that are not so good, and maybe in your own mind think to yourself, oh, that's the bad thing, you know, and then instead appreciate the good thing. So I do think that there's a lot you can do for yourself just by being aware. And for people who are in the early stages, we've talked about this quite a bit, is that if you're eating something that is just really horrible, it's important to persevere, have a couple of mouthfuls. And it seems that after the third mouthful, or after a certain amount of exposure, maybe a minute or something seems to happen, and it just feels more palatable. It's that first assault of something that is so difficult. So those are just some thoughts on parosmia.
We're lucky to be dealing with a very plastics system, and self-correcting in some ways.
So
we can use that to our advantage.
I mean, it's probably a good place to add that, you know, we need to know more about parosmia and all these other things, including, you know, for me also, I think that there's a funny crossover between phantosmia and parosmia that we don't really understand, and hopefully we'll get more information about that with the Sense of Smell Project questionnaire, which is on the website. We're still actually hooking up all the bits of the website, so give that another week or so before you go looking for the questionnaire. But hopefully when the questionnaire is open and it's easy to use, we will find out more about parosmia and fleeting whiffs and all these other things.
Yep.
So yes, so that was the answer to the parosmia question. Okay, right. Before I go on to the studies, and we are kind of moving right along with time here. So we've had a question about theophylline spray. Theophylline spray was studied in the US, and I know that for that study they made some, which they gave out to their patients, and then that seemed to be a good thing. But it's not easy to get your hands on, either here in the UK or in the US. So Simon, take it away on theophylline spray.
Well, yeah, as you say, there is some evidence for theophylline. Giving systemic theophylline is not without its problems. It was initially an asthma
Systemic
treatment
means taking it by pill.
Yeah, or by injection. So giving it into the whole body just to get up here is probably something that you don't really want to do if you don't have to. It was originally an asthma medication, but there are some studies showing that it has helped for some people. So the idea is to use it just in the nose rather than in the body as a whole. And all I can say is that there is some evidence that it has helped. I'm kind of bound by some NDAs to not talk too much about it.
Okay.
So yeah.
All right.
But it is positive. Definitely something we should look at.
Good. Okay. And another question about, and this comes up quite a bit, Flonase and smell loss, because it seems that some people are in the group who have used Flonase and they've lost their sense of smell.
So Flonase is a fluticasone,
right?
Is it? I don't know. We don't have Flonase.
Oh, we don't have it in this country.
Not that I know.
Oh, okay. So
I think it's fluticasone.
Which
is what we call Flixinase. I'll look it up.
Oh, so Simon's going to look it up while I talk to you. Yes. Just a public service announcement while he's doing that. I saw one thing come in on the feed about someone who was self-diagnosing themselves as having post-viral smell loss. If you've lost your sense of smell and you're in this group and you haven't seen a doctor, I think it's a really good thing to go and ask some questions, because losing your sense of smell is not normal, and nobody should take it lying down. So do go and ask for a diagnosis. Right.
Yeah, the problem is, who do you go to?
Well,
and that's
yes.
an ongoing problem that we all have.
Right, so see the previous part of this
Yeah.
broadcast, which will be posted when it's all over. So look for it in about it takes a while to upload, so you won't see it immediately.
So Flonase is fluticasone.
Yeah.
Fluticasone is a steroid, and it calms down the nose, and it's commonly prescribed to people who've lost their sense of smell when the person who is prescribing it hasn't necessarily made a diagnosis, because it's considered generally safe, and it's going to shrink down any swelling in the nose to try and get it to open up and your sense of smell to come back. I think if you read, I don't know about Flonase, but some of them have a loss of sense of smell as a risk factor, as a possible complication. But it's difficult to think how that would happen. I'm not saying it's impossible. I'm just, generally it's better to shrink everything down and open it up. But that doesn't mean that it doesn't cause smell loss. The problem is, again, we're back to this whole thing of how do you know what you know. If you have already got a smell problem or a nasal disease that's going to give you smell loss, how do you know that you weren't going to get that anyway, and the treatment is just ineffective rather than actually causing the smell loss? And that's when it comes down to making the diagnosis, to doing the investigations, to knowing what the treatment is, and to see what's going on. I wondered if that was happening.
We've got a poor network connection.
Why is that?
Do you think that it's going to tell us when the network's good again?
I hope so. I had to move to 4G.
Okay, everybody,
There we go.
Oh, we're back on. Okay. It looks like we lost our connection for a minute there, so we stopped talking immediately. Right, okay. So now I want to talk to you a little bit about a couple of studies that are going on. We'll let that motorbike go by. If you've been looking around in the Facebook group, you will see that I've been doing some research with the University of Reading, which is so exciting, mostly because the idea for it came from you. And this is a great example of how patients working together can actually do something for themselves. So if you are able to come to the University of Reading, which is not that far from Heathrow, not too far from London, if you want to come and visit us, we would love to see you. We are working with patients right now, so it looks very exciting, and it's going to really, I think, be a game changer, we hope. So if you're interested in that, leave a message here in this feed, or you can contact me at chris@abscent.org, and make sure to put the word parosmia in the subject heading, and I will send you the information.